Infertility is defined as the inability to conceive within 1 year of regular unprotected intercourse. It can be primary or secondary. Primary means who has never conceived. A secondary infertility means a previous conception is there. It can be a live birth, it can be a miscarriage, but whenever there is a previous conception, it indicates secondary infertility when the person is not being able to conceive after that incident, trying for more than 1 year. The incidence is around 85 to 90% of healthy young couples. So, in the reproductive age group population, primary infertility affects about 10 to 15% of the people. And when to investigate, that is an important factor. So, for women who are more than 35 years of age, the investigation should be started at 6 months instead of 1 year, because as age advances, the chances of conception decreases. So, the infertility can be caused by both due to male factors, due to female factors, and a combination of both. And there is a small subset which is known as unexplained infertility, where everything is normal, but in spite of that the problem is there. So, it is around 30% for female factor contributing to it, 30% male, and the rest is like it is either both or a combination of both, or it is unexplained infertility. So, for a normal pregnancy to come, what do we need? So, we need a normal uterus, functioning, that is patent fallopian tube. One fallopian tube is enough for conception. Definitely regular ovulation. The endometrium, that is the lining of the uterus, has to be receptive. The corpus luteum, which is formed after rupture of the follicle, has to be producing good amount of progesterone, and definitely healthy spermatozoa. Two terms you should know, that is fecundability and fecundity. Fecundability is the probability of achieving a pregnancy within a single menstrual cycle. It is the probability of achieving a pregnancy, and fecundity is the probability of achieving a live birth. So, there is a subtle difference between the two. One is achieving a pregnancy, or other is achieving a live birth. So, we are starting with the female factors first. So, as we know, there can be uterine causes, there can be tubal causes, there can be ovarian causes, there can be peritoneal, cervical, many causes. So, in a the female factors are ovarian, which is amongst the female factors contributes to around 30 to 40%, the most common being ovulation disorders and decreased ovarian reserve. These two are the most important factors for infertility. Decreased ovarian reserve is particularly important in the modern times, as people are marrying at a later age. Decreased ovarian reserve is definitely a problem, and we see this in many cases. Like when you are practicing infertility or something, people come at around 35, 36 years of age, trying for 1 or 2 years and not conceiving, and by 36 their egg count is quite low. So, diminished ovarian reserve is definitely a problem. Luteal phase defect, luteinized ruptured follicle, they do contribute, but not as important as the first two. Then there are tuboperitoneal factors, that is tubal block, there can be peritubal adhesions, uterine factors, cavity distorting lesions like an submucous fibroid. Then endometrial, of course, receptivity, as I told earlier, is very important. Asherman syndrome, that is intrauterine synechiae. So, there are adhesion bands inside the inside the uterus, breaching the endometrium. So, the endometrium can't grow. So, it can't get receptive actually. Congenital malformations in some cases. Cervical factors, thick cervical mucus, anti-sperm antibody, and pelvic endometriosis. Sexual dysfunction is also an important factor, vaginismus, which we come to see in our OPDs quite commonly these days. So, first we come to ovulation. Ovulation and anovulation has been classified by the WHO. This is a 1973 old classification where they have classified into 4 types, type 1, 2, 3 and 4. So, type 1 is hypogonadotrophic hypogonadism, that is when your hypothalamus or the pituitary or both are not working properly. So there is very low or absent gonadotrophin releasing hormones which comes out from the hypothalamus. They generally stimulate the pituitary to produce the gonadotrophins, which are follicle stimulating factor and luteinizing hormones, and they in turn act on ovary to stimulate to produce develop the follicles and produce estrogen and progesterone. So type 1 is hypogonadotrophic hypogonadism, that is when there are low gonadotrophins, low FSH, low LH. Type 2 is normogonadotrophic hypogonadism. It is the most common factor and generally seen in cases like PCOD. So here the gonadotrophins like LH, FSH are basically normal. Ratios can be altered, as you know it happens in PCOD. The type 4 is hypergonadotrophic hypogonadism. This generally refers to premature ovarian failure. So in premature ovarian failure, the ovaries are not functioning. So as a result, there is no secretion of estrogen. So there is no negative feedback to brain, that is your hypothalamus, and resulting in a high LH and high FSH. So it is hypergonadotrophic, increased FSH and LH is there, but there is little or no estrogen in the body, and type 4 is hyperprolactinemia. A recent classification has come in 2022 which has, it's a FIGO classification known as Hypo-P. It is a little bit different. It has segregated the type 1 of WHO into two types here, like type 1 is hypothalamic, type 2 is pituitary causes, type 3 is ovarian causes, and type 4 is polycystic ovarian syndrome. A little bit in detail, like hypothalamic pituitary, some of the few examples in hypothalamic causes like Kallman's syndrome is a rare genetic disorder where there is failure of the GnRH, that is the gonadotrophin releasing hormones. Neurons, they fail to develop, and as a result there is no GnRH hormone. No GnRH hormone means there is nothing to stimulate the anterior pituitary to form FSH and LH. Then again stress, anxiety, eating disorder, you all know that is a cause of primary hypothalamic amenorrhea. So that can also contribute to the factors. Pituitary causes Sheehan's syndrome. You have just done a PPH drill. So in cases of like when there is severe, sometimes in severe PPH, there is profound hypovolemia and shock, and that leads to anterior pituitary necrosis. So that might cause the same thing, like no FSH, no LH, no stimulation of the ovaries, no follicles, no estrogen, and pituitary tumors. So this is some of the examples. There are many more causes. Amongst the pituitary tumors, prolactinomas are important. Prolactinoma can cause, because they secrete prolactin, and can cause anovulation, oligoovulation, and infertility. As I was talking about the decreased ovarian reserve. So what is ovarian reserve? It is defined as the number of oocytes remaining in the ovary at any given time. So as we all know, women are born with a specific number of follicles or oocytes. At birth, it is around 1 to 2 million, which comes to around 30,000 at puberty and 25,000 at 25 years and 8,000 at 40 years. This decrease is continuous, and it occurs because of apoptosis and because of cyclical ovulation, because at any time ovulation is happening, a cohort of 6 to 7 follicles starts developing, and then of them one develops. So the other 5 to 6 actually gets মানে ওগুলো খারাপ হয়ে যায় আর কি, মানে তৈরি হয় না আর কি। But this and also the quality of oocytes decreases. So একটা কি হয়, বয়স হলে একটা the number of oocytes are decreasing, and number 2 the quality of oocytes also decrease, and these two factors they causes less fecundity as it advances, and after 35 years the rate of decline is very rapid. So after 35 years chances of conception decreases, like because of decreased ovarian reserve. As I was telling, physiological cause is advanced stage. Pathological can be when the ovarian reserve is diminished in a woman compared to others of the same age. It can be genetic, it can be autoimmune, it can be because of radiation or chemotherapy. Ovarian pathology like cysts, endometriosis, they can also damage the ovaries and cause decreased ovarian reserve. Lifestyle factors, smoking can also causes a decreased reserve. So, other factors are luteal phase defect. In this case, there is decreased progesterone secretion from the corpus luteum, inadequate secretion. So, as a result, the endometrium is not receptive and implantation can be a problem, leading to infertility. And polycystic ovarian syndrome. Polycystic ovarian syndrome, there is a different chapter and it is a big lecture on it, but in short, it is one of the most common cause of oligo-ovulation and anovulation and a leading cause of infertility. So, according to Rotterdam Consensus 2003, it is defined as the presence of 2 out of these 3 factors. These are the patient has to have oligo-ovulation or anovulation, features of hyperandrogenism, which can be acne, acanthosis nigricans, then hirsutism, hair fall, and ultrasound feature of polycystic ovary, which is at least 12 antral follicles of 2 to 10 diameter or an ovarian volume of 10 ml in at least one ovary. Endocrine disorders, as I told, hyperprolactinemia can cause oligo-ovulation, anovulation. Hypothyroidism, it can also lead to infertility because altering the peripheral estrogen metabolism and disturbances in GnRH pulses. After the ovarian factors, we come to tubal factors, and we all know like ampulla is the part where the embryo actually forms. So, the fertilization occurs in the ampulla of the tube. So, at least one functioning tube, fallopian tube is absolutely necessary for a natural conception. So, women with bilateral tubal blocks suffer from infertility in 100% cases. So, and tubal disease can affect any segment of the tube and cause blockage, narrowing or dilatation, which is we call hydrosalpinx. The common causes of tubal disease are infection. The most common organisms are chlamydia and gonococcus. Often they are asymptomatic and the person does not even know that the person that she has some blocked tubes or PID. Tuberculosis, surgery, salpingectomy for ectopic pregnancy. Some people already have gotten tubal ligation, and it has so happened, there have been cases when after the ligation both the kids have expired due to some reason, and then they come back to again try for pregnancy, and then with bilateral tubal ligation we have to do something about them. So, endometriosis, congenital tube defects, but most common is infection, endometriosis. Sometimes bilateral ectopic pregnancy also happens, leading to a salpingectomy, and then later on it causes for infertility. So, some of the mechanism of tubal factor infertility, that is endosalpingeal damage causing stenosis, hydrosalpinx, blockage of tubes. Important another factor is peritubal adhesions disrupting the normal tubo-ovarian relationship. So, like as in pelvic endometriosis, the endosalpinx remains untouched, nothing happens to the cilia or the mucosa, but because of the altered tubo-ovarian relationship, the tubes, the fimria cannot pick up the oocytes, and that might lead to infertility. Additionally, there are many other factors in endometriosis. Altered tubal motility, impaired pickup. This is a picture of hydrosalpinx. So, sorry, you can see like the other picture how the tube has become thickened, and this is the HSG which is showing the initial part. So, this initial part of the tube is okay, so but this is distal hydrosalpinx. So, if we say the initial part, the proximal part is okay, but the middle and the distal part are all thickened, and so this also are like can cause I mean definitely a cause of infertility. So uterine factors, the uterine factors are mostly about endometrial receptivity. So endometrial receptivity is essential for successful conception. That is, the endometrium should be receptive for effective nidation and growth of the fertilized ovum. So endometrium has to be thick, the blood supply has to be good. These are the two important points. And if the endometrium is very thin, for example Asherman syndrome or intrauterine adhesions, which happens due to vigorous uterine curettage or any other uterine surgery. Then endometritis, where again the endometrium, the inner lining of the uterus is affected. Endometrial polyp, where there is a thickening of the endometrium localized. Adenomyosis, endometriosis, they all affect the endometrium in some way or the other, causing a decline in its receptivity. Asherman syndrome causes adhesions and thin endometrium. Some other causes are fibroids. Fibroids generally are not considered like important factor for causing infertility, but it can cause, particularly if there are submucous fibroids which are distorting the cavity. Also an large intramural fibroid in the cornual region might distort the tube and cause obstruction of entry of sperm to the tube and infertility. Emarcate syndrome, you must have already read about it, where there is congenital aplasia of uterus and upper two-thirds of the vagina with normal ovaries and normal 46XS karyotype. And very rarely Mullerian anomalies like septate uterus. Septate uterus more commonly causes recurrent miscarriage, preterm labor, but it might cause infertility in some cases. And transverse vaginal septum. But transverse vaginal septum is generally diagnosed at an earlier time when there is cryptomenorrhea and so that time it is taken care of actually. Some cervical factors, we don't evaluate this to certain extent these days, but it can be as I have written in the anatomic defects hampering sperm ascent by preventing the external loss to come in contact with the deposited sperm, which can be if the cervix is elongated because the sperm is deposited in the fornixes, and if it is elongated it does not come in contact. So congenital elongation, second degree prolapse, cervicitis causes purulent cervical discharge. There can be immunological like anti-sperm antibody or sperm immobilizing antibody in the we do not test nowadays for this antibody. So if suppose in unexplained infertility, when the person is not being able to conceive, it might be sometimes it happens due to this immunological causes, but in unexplained infertility one of the treatment of choice is intrauterine insemination. So when we do intrauterine insemination, these factors are overcome. I will talk about it later. Vaginal factors. Now vaginismus, this one we come to see in our OPDs quite often actually. It is involuntary spasm of the pelvic muscles surrounding the outer third of the vagina, especially the perineal muscles and levatorinae, which makes intercourse virtually impossible in its severe form, and it is not uncommon. People do not say, but it does happen actually. And deep dyspareunia. So the pain is so much that the woman avoids having a physical relation with the husband. So that might also lead to infertility. Endometriosis, I am written it separately. So we all know what endometriosis is. It is the presence of functioning endometrium, both glands and stroma in sites other than uterine mucosa. It causes a chronic inflammatory reaction resulting in adhesions and fibrosis, and also ovarian cyst formation. So this adhesion and fibrosis is very dangerous. Affects 10% of women in reproductive age group, but amongst infertile women the prevalence is around 30 to 40%. The common sites are endometriotic cysts, ovaries, which are also called chocolate cysts, pelvic peritoneum, pouch of Douglas, uterosacral recurrence, rectovaginal septum. What endometriosis does is that it completely alters the pelvic architecture, the normal anatomy. Plus there are many other factors like cytokines are released, the peritoneal fluid, character of the fluid is altered, there are cysts. So it causes infertility in many ways, and also is a major cause of pain and to the ladies. In infertility, as I told, but mechanism of infertility in endometriosis, in minimal and mild it is impaired uterotubal transport, ovulatory disturbances, some abnormal peritoneal fluid and increased sperm phagocytosis by macrophages, impaired oocyte and embryo quality, implantation failure. These are like specific to endometriosis only kind of. Are in moderate to severe endometriosis, destruction of ovarian cortex, diminished ovarian reserve, pelvic adhesions, deep dyspareunia, all contributes to infertility. So this is just a picture. These are like minimal these are endometriotic deposits. This is mild endometriosis, and this is like with a chocolate cyst. The chocolate material is draining out. Male factor infertility, it can be due to testicular causes, pre-testicular causes and post-testicular causes. The pre-testicular causes includes genetic disease like Klinefelter syndrome, congenital can be undescended testes, infection, mumps orchitis, very important, causes azoospermia if it happens in the adult age, vascular varicocele, torsion, immunological, pre-testicular, some of the endocrine problems can also cause semen parameters to go down, as we see in women like diabetes, hypothyroidism, hyperprolactinemia, hypogonadotrophic hypogonadism can all affect the male as well. Post-testicular is epididymis. Epididymis infection can occur, vas deferens, congenital absence of the vas deferens, vasectomy, surgical trauma. Others, smoking, this is extremely important, it causes oxidative damage, and many cases where we do not find any cause, the smoking, if they can, the person can stop, there is generally an improvement in the semen parameters. Male sexual dysfunction, erectile dysfunction, retrograde ejaculation, these are also problem in the current days. Hypospadias, this is an anatomic defect where the opening is on the undersurface of the penis and not at the tip. And iatrogenic, antidepressants, anticonvulsants, cytotoxic drugs, they can all again cause a decrease in spermatogenesis, ejaculatory problem and lead to infertility. So when a patient comes with the problem of infertility, how do we approach? Detailed history is very important, menstrual history. This gives us definitely an idea like whether the person is ovulating regularly, like a regular 28-day cycle or a regular 28, even 35, but regular cycle generally indicates ovulation. In polycystic ovaries, like generally the lady complains of delayed periods, skipped periods, 45, 90 days cycles, scanty flow and all those kinds. So from history only you can understand whether the menstrual history, that what can be the problem to some extent. Sexual history is important because the frequency of intercourse. In these days when everybody is working and especially in the IT sector, this is a problem. Very frequent, infrequent intercourse, and then people are coming telling you we are not conceiving. Medical, surgical, obviously medical can be like diabetes, history of hyperprolactinemia, surgical as I told, any ectopic pregnancy, laparoscopic or ovarian cystectomy, laparotomy, history of tuberculosis in medical, all can lead to can give us ideas. Family history of menopause, for example, if the mother or a young girl, for example, it has happened, I have seen patients of 28 years with premature ovarian failure. So that might be an idiopathic one, but it does happen at, like, I have seen other patients at 33, 34 years, and they give the history that their elder sister or mother had also had menopause at an early age. So in such cases you should ask about the family history, also about any premature menopause. Drugs, definitely contraceptive history is important, whether they are using any contraceptive. Physical examination is as we do in all others, but features of BMI, because polycystic generally obesity is there, hyperandrogenism like acne, hirsutism, acanthosis nigrans, that is your insulin sensitivity, which like black discoloration on the neck, the underarms, they are often present in PCO. Galactoria can be there in hyperprolactinemia, so breast examination, but patient generally say there is some discharge from the nipples if galactoria is there. And the basic per abdominal vaginal examination. For male, stature and BMI important. Scrotal penile examinations for hernia, varicocele, atrophy of testes are also should be done actually. And now we come to the investigations. Okay, so what are the investigations? For male factor, whenever a couple comes, husband semen analysis is always advised, because we need to know whether the semen parameters are okay or not. So this is always advised. We generally see the female has done many tests, but even a single semen analysis has not been done, and when we do the semen analysis we see maybe there is no sperm or very low sperm, no motility, that kind of stuff. So husband semen analysis should always be done initially, to rule out at least the husband has got any problem, and there are special tests like 3 to 5 days abstinence is important. If you give a very short or a very long abstinence period, the quality of the semen analysis might not be proper. Special tests are DNA fragmentation index, Y chromosome microdeletion. These are advanced tests which are done in cases of recurrent pregnancy failure, recurrent implantation failure, and all those kind of stuffs. Female factors. So we know ovaries needs to be functioning, test for ovarian reserve, test to confirm ovulation, tubal patency tests, ultrasound for uterine ovarian pathologies, and special tests are karyotyping, endometrial receptivity assay. This is endometrial receptivity assay is not done regularly. It is generally done in vitro fertilization and IVF when multiple IVF cycles. In spite of that, there is no pregnancy. So we go investigations to detect the female factors. Just a second. That test that we do to detect ovarian factors. Okay, first is ovarian reserve testing. So this can be done by, the most commonly done is by serum AMH, which can be done in any day of the cycle, unlike serum FSH, which is done on day 2 or day 3 of the cycle. Serum AMH is more commonly done, and it should be at least more than 1.2 nanogram per ml. Less than 1.2 nanogram, we call it poor ovarian or decreased ovarian reserve. Serum FSH we do less of these days to know the ovarian reserve testing. We do it more in cases where there is irregular periods advanced stage, to know whether menopausal or not, perimenopause or not. So the main two tests are serum AMH, antral follicle count by TVS. So, and this should be done between day 2 or day 3 of the cycle. The antral follicle count should not be done by abdominal USG. It should always be done by transvaginal USG, and the follicles are counted to be, should be 2 to 9 millimeter in diameter, and there should not be any cysts, follicles or things of that sort when we are doing antral follicle count. Between serum AMH and antral follicle count is more correct. Then this is the ovarian reserve testing. Then we go for test to detect ovulation. We are talking about the common tests that we do in general in our practice. Serial folliculometry. This is done day in day out. We do it here also. So it is serial transvaginal sonography. Baseline scan is done on day 2, day 3. to know the antral follicle count, to rule out any cysts, to rule out any other pelvic pathology, and then again on day 9 or 10, because generally ovulation occurs at around 14 days. So, maybe 9 or 10 we will be able to see the size and then go forward from there. So, every 2 to 3, 1 or 2 days till follicular size is of 18 to 20 mm, and then again we call after few days to document ovulation, when we will see the follicle has ruptured and there has been a formation of a corpus luteum. Urinary LH detection kit. This is done by many women these days. LH surge detection can be done. It indicates when it is positive, it indicates that ovulation most probably will take place 24 to 36 hours after it comes positive. Urinary LH testing is done generally in the evening and generally between day 11 to day 16 of a regular 28-day cycle. Serum progesterone should be more than 10 nanogram per ml on day 21 of the cycle. If it is less than 10 nanogram, it generally indicates absence of ovulation, because following ovulation corpus luteum is formed and corpus luteum secretes progesterone. So, if the progesterone is low, it indicates anovulation. The other methods includes BBT, that is basal body temperature fall and rise, spin bar kit test, which is the stretchability of cervical mucus. The cervical mucus becomes stretchable before ovulation under estrogenic effect. Fern test, which is again we do not do at all nowadays. Presence of ferding even after 21st day suggests ovulation, and its disappearance is presumptive evidence of ovulation. And endometrial biopsy. This is also not very commonly done these days. So, generally done in the mid-luteal phase around day 21 to 25 of the cycle. Subnuclear vacuolation is the first sign of ovulation. If proliferative type of endometrium is found at this time, which should not be there, it indicates anovulation. It also helps detection of luteal phase defect, because if progesterone has been secreted, then the character of the endometrium should be secretory. Tubal patency test. So, it is generally done between the day 6 and day 11 of a menstrual cycle. The reason being we want to do it before ovulation, so that later on if we do, and if suppose there has been a pregnancy, undiagnosed developing pregnancy, while doing the test we can dislodge it and destroy it. So, there are various methods. The first method is HSG, which you all know about. Radio-opaque dye, which is mostly an iodine based dye, is introduced into the uterine cavity through a cannula. Both tubes can be assessed and site of blockage can be seen, the advantages. Cavity is also visualized. So, here we can see that these are the tubes and this is spillage of the dye. So, that indicates patent tubes, and we can see how the uterus is looking. Okay. So, it is a normal uterus. The disadvantage is that it is painful. There is risk of radiation because we have to do X-ray, and spasm of tube. There can be spasm of the tube because it is a little bit painful, and that spasm can cause blockage of the cornua, and that might give a false diagnosis of blocked tube. The next one is Saline Infusion Sonography, SIS, which is also known as SSG. So, this is a transvaginal sonography is done, followed by infusion of around 50 ml of normal saline, and then resumption of the scanning. Presence of fluid in the pelvic cavity, if absent in the initial can, indicates patent tubes. So, this is some of the pictures. This is uterus, these are the fluid in the adnexa, and this indicates tubes. And this is the cavity, this is the cavity. So, the cavity is okay. So, uterine and ovarian morphology can be assessed. The advantage, because we are doing a USG sonography initially, it is less painful, no radiation risk. The disadvantage is that it cannot distinguish between unilateral or bilateral patency. It can indicate that at least one tube is patent, but cannot tell with confirmation that both are patent or only one is patent. The newer tests are Hypogonadotrophic, which is similar to SIS, but instead of normal saline, a positive contrast agent is infused, Advantage is that individual tubes can be delineated. The morphology assessed, tubal block and the site of blockage can be ascertained. And laparoscopy, hysteroscopy, dye test, it is the gold standard for assessing fallopian tubes. So, it is an operative procedure done under anesthesia, directly visualized. Methylene blue dye is pushed into the uterine cavity. Presence of dye in POD confirmation is by direct visualization. What are the advantages? If blockage or hydrosalpinx is seen, it can be surgically treated. So this is the uterus, this is a tube, and this is methylene blue in the pouch of Douglas. So, and also the fimbria out here is stained blue. So, that indicates like there is tubal patency of both sides. Same here, there are tubes and these are the two tubes, this is uterus. The other advantage is that since it is a laparoscopy procedure, any other pelvic pathologies like peritubal adhesions, minimal and mild endometriosis can be assessed. Hysteroscopy is generally done with laparoscopy dye test, and the uterine cavity can be assessed, uterine polyp can be removed, submucous fibroid if small can be removed, and a proximal block can also be relieved by proximal tubal cannulation, hysteroscopic proximal tubal cannulation. Uterine factors, it is mostly ultrasound, and nowadays the 3D ultrasound helps in determining the morphological defect. Others are saline infusion sonography, MRI. So, normal uterus looks something like this on a 3D ultrasound. This is a partial septate uterus again on ultrasound, and this is intrauterine synechia. So, these are bands inside, this is one band, this is one band, and fluid has been instilled. So, it can be demonstrated more nicely. Diagnosis of pelvic endometriosis is again is by ultrasound. Sometimes symptoms point towards the diagnosis. MRI helps in some cases, but definitely the confirmation is by laparoscopy and open surgery and histopathological examination. Now, male factor, we did how to detect the female factors, now we are coming to the male factors. So, the most important test is definitely the semen analysis, as I had told, after 2 to 5 days abstinence. Nowadays the abstinence timing is coming down, we generally say 2 to 3 days. So, these are the normal parameters. Volume has to be more than 2.4 millimeter. These are minimal standards basically. It is normally volume is around 2.5 to 3 ml, but these are the minimum standards. Volume has to be more than 1.4, sperm concentration should be more than equal to 16 million. Total motility has to be 42%, of which progressive motility has to be more than 30%. Morphology 4%. More than fructose should be present, and leukocyte is basically pus cells, it indicates whether there is infection. 1 to 2 million is normal, more than that indicates some kind of infection. What is the importance of fructose? If it is absent, it indicates ejaculatory duct obstruction basically, or congenital absence of seminal, some problem with the ejaculatory duct. Other investigations that can be done in male factor depending on the history we have taken and the examination are bloods like FSH, testosterone, thyroid, TSH, prolactin, fasting, diabetes for diabetes. Nowadays we also do scrotal USG, transrectal USG, which is in place of vasogram, generally replaced by TRUS. Testicular biopsy usually not done. Karyotyping as in Klinefelter's immunological test, all this, but mostly it is the semen analysis. Semen analysis we do, if it is okay, then okay, if it is not, we proceed accordingly. Bloods we do, but these are generally not done. Scrotal USG, transrectal USG is done depending on the case, depending on the examination, not all patients. And these are some terms that you should know. relating to the semen analysis, like normozoospermia, when all semen parameters are normal, oligospermia, when sperm concentration is less than 16 million per ml. If 5 million, it is called severe oligozoospermia. Teratozoospermia, morphological, less than 4% sperm is normal. Astheno, that is motility, total sperm motility less than 42%. Asthenoteratozoospermia, that is motility is less as well as morphology is less. Azoospermia, this is important, there is complete absence of sperm in the ejaculate. And another term called aspermia, that is absence of semen, that is there is no ejaculate. These two are important. Azoospermia is very common as is oligozoospermia, terato and astheno. Combining oligo, terato and asthenospermia, we normally call it, abbreviate it as OAT. Oligoasthenoteratozoospermia, and it is common. So, treatment of the infertile couple depends on the cause. We have to find out the cause and then go forward. Female partner, ovulation induction and timed intercourse. So, when the pathology is basically ovulatory dysfunction, we go for ovulation induction. It can be by oral ovulogens like clomiphene citrate or letrozole, or by injections, gonadotrophins, that is FSH, follicle stimulating hormone, or HMG, human menopausal gonadotrophin, which has got both FSH and LH, and it can be a combination of both. And whenever we are doing our ovulation induction, serial monitoring of the follicle should be done. And generally HCG injection is given at 17 to 18 mm size for gonadotrophins and 20 to 20 for letrozole to release the oocyte with follicular rupture. Patient is asked to have regular or alternate day relation with the husband when the follicular size is around 14 to 16 mm till after 1-2 days after follicular rupture. The ovulation induction, that was untimed intercourse, then ovulation induction and intrauterine insemination. When 3 to 6 cycles of ovulation induction and timed intercourse does not give any result, often intrauterine insemination is done. But in IUI, often in ovulation induction, we generally go for 1 follicle. In IUI, 2 to 3 follicles we generally prefer. And ovarian drilling, this is done sometimes in polycystic ovarian syndrome. Polycystic ovarian syndrome is very resistant, sometimes very resistant to induction of ovulation by conventional methods like ovulation induction with CC, letrozole or with gonadotrophins. Then sometimes patient is generally advised either to go IVF or ovarian drilling. Ovarian drilling is comparatively cheap and gives better result in some cases. If the patient is young, they can try for some months together without going for an expensive treatment. So, it is done laparoscopically, multiple small punctures, 4 to 6 are done on each ovary. It decreases the hyperandrogenic environment of the ovaries and improves ovulation with or without ovulogens. And anovulatory PCOS, insulin resistance is important in the pathophysiology, and insulin sensitizing agents like metformin and myo-inositol are very commonly used in polycystic ovarian syndromes. Tubal factors, these are the treatment, peritubal adhesions, lap surgery, proximal tubal block, as I told, proximal tubal cannulation, distal tubal block fimbrioplasty or neosalpingotomy, mid-tubal block generally seen in bilateral tubal ligation. Reversal of ligation needs to be done by tubal anastomosis. But however, IVF is considered to be the treatment of choice for all complicated tubal occlusion disease, and in general in the present days for nearly all cases of tubal block, IVF is generally advised. Uterine factors, it depends on what is the cause basically. Lap myomectomy, transcervical resection of submucous fibroid, if there is an intrauterine polyp, removal of adhesions and so on. Cervical factors, if it is chronic cervicitis, you do antibiotics. IUI, as I was telling, for if there is anti-sperm antibody and all those. Treatment of the male factor, like OAT, as I was telling, is oligoasthenoteratospermia. So all the three parameters are less. There is less in concentration, 16 million, there is less motility, less than 40%, and there is less morphology, low, less than 4%. So lifestyle changes are very important. Obesity management, again stopping smoking and nicotine intake in any form, because smoking causes oxidative damage to the sperms. And stopping smoking actually helps to improve the parameters. Antioxidants are given, coenzyme Q10 supplementation. If an endocrinal cause can be found, it should be treated by appropriate hormone supplementation. Male sexual dysfunction, definitely psychosexual counseling, pelvic floor exercise, medications like sildenafil, tadalafil, these are all often advised. Very rarely surgery is advised, which can be cases of varicocele, obstructive azoospermia, hypospadias. And basically treatments for other modalities are IUI with husband semen, IUI with donor sperm, and assisted reproductive techniques. Unexplained infertility, as I told, diagnosis is made in couples in whom all standard investigations are normal, like ovulation is okay, tubal patency, at least one patent is tube, morphology normal, semen analysis normal, but does not conceive. It is a diagnosis by exclusion. Up to 30% of the infertile couples, management is ovarian stimulation and intrauterine insemination and IVF. These are done quite commonly. So I have been talking about IUI. So basically what is IUI? IUI is intrauterine insemination, also called artificial insemination. It is an assisted conception technique that involves the deposition of processed concentrated motile sperm in upper uterine cavity close to the fallopian tubes. Two types, AIH with husband sperm and AID, IUI with donor sperm. So indication cervical factor, like the original purpose, as I had already told, was due to bypass the cervical causes. The other indications of IUI we more commonly do is ovulatory dysfunction, often done after 3 to 2 cycles of failed ovulation induction and timed intercourse, unexplained infertility, minimal and mild endometriosis, male factors, mild oligospermia, asthenospermia, ejaculatory defect, etc. Donor sperm is used in azoospermia, because in azoospermia there is no other option of pregnancy. Either it has to be IVF, and if the person cannot afford the expense, because IVF is definitely expensive, then and if they are open to it, they can use donor sperm, and IUI can be done with donor sperm. IUI procedure is basically ovulation induction. It is also called super ovulation, because in IUI we prefer more than one. Ovulation induction is when one follicle we induce with the hope of getting one follicle. Super ovulation is more than one, but it is 2 to 3 follicles. So the semen is collected, it is processed. The final post-wash sample, which is known as total motile sperm concentration, should be at least 5 to 10 million motile spermatozoa, and processed sperm is drawn in a fine plastic catheter, and 0.5 ml is introduced into the uterine cavity. It is generally done 36 to 40 hours after triggering ovulation with HCG. Can be done with fresh semen, frozen semen. Sometimes it happens the husband stays far, and in that case we can keep the semen sample frozen and IUI can be done. Donor sperm in case of azoospermia. Generally pregnancy is achieved in the first 3 cycles if it has to be come through IUI. And if another thing is, if more than 3 follicles develop, cycle cancel kore dewa bhalo, because chance of multifetal pregnancy is there. Complications of superovulation is OHSS. It's multifollicular development basically, leading to bulky enlarged ovaries, pain, abdomen, collection of fluid in pelvis. In severe cases there can be ascites, respiratory distress, oliguria, and all these cases. But this is more common in IVF than in IUI, though can happen in IUI. And assisted reproductive techniques, what is it? It is defined as clinical treatment and laboratory procedures which includes handling of oocytes, ovarian tissue, sperm, testicular tissue or embryos in vitro, that is outside the body, with the intent of establishing a pregnancy. It does not include IUI, There are various ART procedures. The common one includes in vitro IVF, ICSI, intracytoplasmic sperm injection, and various sperm retrieval techniques, TESI and PESA. What is IVF? The indications basically prolonged duration of infertility with failed ovulation induction, timed intercourse, superinflation with IUI, resistant PCOD, tubal factor, bilateral block, moderate to severe endometriosis, unexplained infertility, premature ovarian failure with donor egg, severe male factor infertility, severe OAT, etc. Basic concept is you basically stimulate development of multiple eggs, and then the follicle size reaches 18 to 20 mm. The follicle is aspirated, follicular fluid is aspirated out, and the retrieved oocytes are incubated with sperm in special incubators with the aim of successful natural fertilization. The resulting embryos are transferred back in uterine cavity either on stage day 3 modula or blastocyst stage. Disadvantage, it's costly, no guarantee of pregnancy and live birth. Success rate is 30 to 40% per cycle. For women less than 35 years, it's good ovarian reserve. Emotional and physical stress is an important factor. And what are the risks? The common ones are multifetal pregnancy. OHSS is not that common with newer modern techniques of stimulation. Injury to internal iliac vessels during OPU, not that common, but multiple pregnancy is definitely a problem. And but still it is an important modality of treatment for patients with bilateral tubal block, poor ovarian reserve, premature ovarian failure, severe endometriosis, severe male factor. So this is just a picture, the stimulated ovary and transvaginal probe, and the transvaginally the ovum is picked up from the fluid is aspirated, this follicular fluid is aspirated. ICSI and just at least surrogacy. Surrogacy will is an arrangement in which a woman agrees to a pregnancy achieved through ART in which neither of the gametes or the embryo belong to her or to her husband, with the intention of to carry it to term and hand over the child resulting from the pregnancy to the person or persons for whom she is acting as a surrogate. In India, it is not permitted for commercial use. It can be done only amongst relatives, and ethical aspect is important. That's it. And but before ending, I must say this is, I don't know how many of you will practice infertility later on. It is a social trauma, and women are often castigated for being infertile. Very true. Many patients come and they say ki amader ekghore kore dewa hoyeche kenona shantan asche na. So empathy is very important while treating the couples with infertility, and every patient's treatment needs to be individualized. There is no general like one single treatment which can be applied to all the patients who come. Each patient has to be individualized because the problem with each patient is different. Okay? Thank you.